Welcome, everybody. How's your afternoon going? Everybody doing good? First question of the day for the afternoon is happy Earth Day, everybody. And has anybody actually gone outside and hugged a tree or felt the earth today? Have you done anything? Tell me in the chat, like if you've done something outside today. Dog walk. Leela, I don't know how you fit that in, but somehow you do it. Multitasker. Okay, Janelle, good for you. You went for a quick walk in the sun. Laura, you ran, Sam. Watered plants, good. Brought a kid to baseball camp. Okay, looking outside. I suppose that does count. We'll give it to you. All right, so I'm Melody, the founder of the WIT Regatta, and you're at the session, Data Sharing is the Key to Healthcare Transformation, supported by Cambia Health Solutions. For those of you that are new to WIT Regatta, it's a gathering to connect women in tech to mentors, peers, and resources to strengthen our community, advance your career, and to learn from one another. And while we're here to focus and elevate women in tech, we also believe that tech is for everyone, and that goes beyond gender. Our hashtag is relationships, the true currency. So our goal is to make sure that you meet your new best friend or your new boss at this event. And the way to do that is through vulnerability and storytelling and participating and going into our breakout rooms and meeting people face to face and linked in with each other and make separate little meetings. So we hope you do that. We're going on our second year here in Seattle with the virtual route, and so we're trying everything we can to make sure that all of us introverts and extroverts are meeting through this box. But we're getting vulnerable and we're meeting each other. We're hearing lots of great feedback of people meeting each other and getting to be friends. And there's some actual job hiring going on too, which is very exciting. So I am going to stop talking now and turn it over to our fabulous sponsor, Cambia. We got Natalie in the house here with us. So Natalie, hello.
Hi, thank you. Thanks everybody for being here and coming to learn more about career opportunities with Cambia. Like she said, my name is Natalie. I am the tech recruiter here. I normally sit in downtown Portland, but right now you're at my house in Northeast. So a little bit about Cambia. So Cambia is a family of companies, but we got started more than 100 years ago in the Tacoma region up in Washington, and we have grown exponentially since then. Today, we are more than 20 companies within our family. We have physical offices in the 4 states, Oregon, Washington, Idaho, and Utah. And because many of our businesses are web-based, we now touch the lives of more than 70 million people nationwide, which is pretty incredible. We are a licensed Blue Cross Blue Shield provider in those 4 states. So that's probably how a lot of people know about us. But actually in 2010, we began investing, launching, and acquiring startups to offer more innovative solutions to the healthcare marketplace. So one of those is just our recent launch of our newest mobile app, which allows you to manage and organize your family's health all in one place. It's called Journey. So you work with a care guide along the way to help assist you. And this is one of our newest products, and we're really, really proud of that. So while each of the companies is tackling a different problem in the healthcare marketplace, they all contribute to our cause, which is to transform healthcare. So that kind of gives you an idea of what Cambia is a little bit about. But I wanted to let you know that I am hiring for a lot of different roles within all of those companies at Cambia. So we've got data scientists, developers, product managers, DevOps engineers, cloud engineers, data architects, design managers, UI, UX designers. And we also have summer internships as well. Those are going pretty quickly. So I would love to connect with anyone that's looking, to discuss further opportunities with Cambia, and connect on LinkedIn. That's a great way to get a hold of me. So enjoy the rest of the event. And now I want to turn it over to Dr. Marion Couch.
Thank you, Melody and Natalie. I appreciate the introductions. And I am Dr. Marion Couch, but I hope that you will not use the word doctor anymore because we're talking about tech things. I'm the Senior Vice President of Healthcare Services at Cambia and also the Chief Medical Officer. And I've practiced medicine for 30 years, over 30 years. And I've always had an interest in the technology side. I will echo what Natalie said. The company is got a phenomenal footprint, and we'll go over that a little bit later on. And it's very innovative, which is great. I also want to show you my twins row. So when you talked about regatta, I asked me to speak. I'm like, I'm here. One of the things I've learned is that when you're not with a good team, you can catch a crab, which means your oar is trapped in the water. It hits you in the chest, then you go flying out of the boat. So it's all about teamwork. And the great news is I have a great team with me today, and you're going to hear more from them than me. We have a great panel with Anna Taylor from Multicare Connected Care, Jocelyn Keegan from Point of Care Partners, and Latoya Thomas on Doctor on Demand. And I'm going to ask each of them to introduce themselves in the way that they want to be known. So Anna, can I ask you to introduce yourself?
Yeah, thanks, Marion. I appreciate it. I'm Anna Taylor. I work for Multicare Health System, which has a subsidiary called Multicare Connected Care, which is our population health engine. And I've been in healthcare accidentally. I'm an engineer in healthcare accidentally about 13 years now, a little over. And I have a heart for wanting to make things better for humans. So my mission in life is to leave this world just a little bit better for the ones after me, especially my two small babies. And I feel like I can do that in tech, being an engineer in healthcare. So that's who I am. And I work for Multicare.
Anna, thank you so much. That perfect introduction. Jocelyn Keegan, can I have you introduce yourself now?
Sure. My name is Jocelyn Keegan. I work for a small boutique consultancy called Point of Care Partners, and we specialize in healthcare IT strategy. And I also have an opportunity to work with Marion and Anna on one of my projects, which is I'm the program manager for DaVinci, which we'll probably touch on in some of our conversation tonight, which is really leading the charge to develop really the rails in the recipes for healthcare providers and payers to make data exchange happen better and for interoperability to happen. And like Anna, I am a firm believer in change. I'm a mom. I have two boys, 14 and 16-year-olds. So they used to like me. They'll like me again someday. And I think that if you're going to work, you need to do stuff where you feel like you're impacting change in the world. And I think that, each of us are change agents on a day-to-day basis, that change is a human-powered activity. And that when people work together to actually break conventional wisdom, amazing things can happen. I'm really fortunate that I've been able to mash up sort of that drive for change with a technology career. And like Anna, I'm sort of accidentally here. I have a BA in history and spent the first half of my career in financial services technology. So anything is possible if you put your mind to it and you say yes and are open to opportunity. So really excited to talk to you guys tonight. And thanks for inviting me to speak. I'm going to just put a little plug in. I get to work with the Cambia team on a day-to-day basis, and they're amazing, and they really are making the world a better place. So.
Thank you, Jocelyn. I told you we had a great team today. Thank you. Latoya Thomas, Doctor on Demand, can I have you introduce yourself? Last but not least.
Absolutely, Marion. I appreciate you being the coxswain in all of this, just so that we can play up some of those crew terms here. I think that's the role that you're playing here. And I also want to thank you, you and Cambia, for sponsoring this panel, and also for just Cambia and Regents for our own ongoing partnership with you all for the past few years. We've been really just thrilled to provide virtual care services to many of your members across the country. I'm Latoya Thomas. I'm the Director of Policy and Government Affairs cares for doctor on demand. We're a virtual care practice, and we provide patients with 24/7, 365 access to safe, quality, urgent care, primary care, and behavioral health services in all 50 states and DC. We do so through a suite of tools such as video, voice, as well as secure messaging. For myself, I've spent the past decade working with actually state and federal policymakers to develop policies that facilitate a more equitable, affordable, and accessible delivery of care for all in the care continuum. I'm thrilled to be here today. I will follow the theme of being here by accident. I never, ever intended to work in the virtual care space, the telehealth space. But when you say yes, and when you have wonderful mentors who are there to champion you, it just makes the process that much easier. So thanks so much.
Thanks, Latoya. I really appreciate that. And we'll be circling back to you about the policy piece because that's an important part of this. So interoperability is a big word. And I'd like each of you, and I'll start with Anna and I'll go then to Jocelyn and Latoya. Please tell me in very clear terms, what does interoperability mean and why should I care in healthcare? What does it mean and what does it mean for healthcare? Anna, can I ask you to start?
Yeah, I'd be happy to kick that off. Thanks. To me and to the work that we do in trying to unlock data out of our care system. So we're a healthcare provider. We have data in our electronic medical record, and it's stuck in there. So what we are realizing is that this word interoperability becomes very important and a key capability to success in the future because our data is everywhere. And we want to take the best of breed of each technology that's built out there and be able to make them work to better the care that we're enabled to deliver through our electronic systems. So simply said, it's plumbing, it's data plumbing. How do you get data from point A to point B? How are you most efficient, highest quality, quality in means of what's in it and also how you do it. So both of those means. To me, it always go to plumbing. That's where the analogy goes for me. And it's really important for patient care to be enabled to put that data in front of the provider. And the only way we do that is through really standard plumbing.
Jocelyn, how would you describe interoperability to my husband who's not in healthcare? What does that mean?
Well, we joked around in our prep session that it's just making sure that Anna has the data wherever she needs it, whenever she wants it, and that she's happy, right?
Yeah.
But to build on, I think her point, I think that it's about information equity and making sure that whoever is part of the care team for a patient at a given point in time has access to the right information to make the best care decisions about that patient. And, you know, as we move into a world where we're really changing and reforming the way we pay for care and how care happens, and I know we'll dive into sort of the pandemic and sort of that impact, I think, of breaking down a lot of the conventional wisdom out there. I think that to me, interoperability means, you know, everybody operating in a synchronized way so that they can get the information they need at the time and workflow when they're doing something that they need, and that it's actionable and it's relevant and it's correct, and that information can move along with the patient during the patient's journey, because that's how we're going to be able to affect the change that we need to have occur for us to, you know, bend the curve on patient outcomes and help people lead healthier lives. And as long as we keep that in mind, I think the rest of sort of the noise, we don't talk about interoperability in banking. We don't talk about interoperability, you know, with your travel sites. We need to make it, like Anna said, like it's plumbing and you just never think about it. You turn on the tap and it's there.
Latoya, from your perspective, what does interoperability mean and why do we care in healthcare?
Yeah, I love what Jocelyn just said in terms of synchronization and then acting off of the data and the information that you possess. I'll say for us at Doctor on Demand, interoperability is a really important component and feature that enables us to deliver high quality care. I'll say again, we're an exclusively virtual healthcare provider, and we're embedded in this larger health ecosystem in which we have to work with specialists, labs, pharmacies, payers, if you will. And in order to do so, being able to use a number of the tools that we have at our disposal, whether it's tools that allow patients to have some level of price transparency so that they know exactly how much they intend to pay for their visit at the time of their visit. The ability for us to, after a visit after a visit that our providers have with the patient, to determine whether or not that patient needs a smart referral to a specialist, and to be able to take that patient's health record with their permission and refer it to a specialist in network for them. Our ability to do integrated labs. I think we underestimated that particular feature up until last year. I think before the CARES Act officially passed, and there was a lot of confusion as to whether or not you needed a provider's order to get a COVID test, we realized that we already had exclusive relationships with LabCorp and Quest Labs, and our patients trusted us, their families trusted us. So not only were they coming to us with questions just about this new condition that was the coronavirus, but they realized that they were able to get rather quick assessments to determine whether or not they needed a COVID test. But we were also able to provide them with the assurances and the types of services that they needed to mitigate the spread and really keep people at home. I think for us, interoperability is making sure that we can help our patients navigate their healthcare journeys. And we do that obviously with the exchange of data with a variety of partners. But I think our stakeholders, again, are broader than just, payers and whatnot. They include patients and their families as well.
Could I just add and take my hat off as moderator and just add from a clinician's point of view, I need you to understand how vitally important this is. There is no plumbing in certain places. When I started, I would say 4 or 5 years ago at a large academic health system, there were departments who were still on paper. Secondly, when my patients would ask for a referral, we would fax, or if we were really lucky, would go into the cloud. When you go to get your medical records, they're printed or they're handed to you on a CD-ROM. When images are given to me, because I was a specialist, and they would come to me, there would be a proprietary program and a CD. And who has a CD on their computer anymore? Not a problem. We still got the CD. And then you try to figure out what the proprietary program was. And it's, I have to tell you, the concept of having these lines and these plumbing for data information, it's real, folks. It's a real issue. And to not fix that is like renovating your house and thinking, oh, I'll just leave the plumbing alone. If some of you have done that, know how that absolutely doesn't work. So my point is, for the members and patients, this is a huge, huge issue. Thanks, everybody. Hey, Latoya, you're up next. Because of your background, I wondered, could you describe to us policy initiatives already underway and the importance of having bipartisan support?
Yeah, I appreciate that. I did want to piggyback on just one thing that you said that I think is germane, is this concept of for policy, and whether it be interoperability or just kind of digital health writ large, that there are times that policy is behind. And in some of the use cases that you just described, I'll just take imaging, for example. I think historically, there's been this concept of taking a diagnostic image, you can say an X-ray, and storing that information and forwarding it. Well, that concept does not include the cloud. And so how do you work with policymakers just to define kind of this evolutionary process that is not quite, it's antiquated, right? We're using the cloud, we're using all of these other kind of sophisticated means of exchanging information. So I just wanted to piggyback off of that. With respect to interoperability and policy, without getting too much into, I think, a political timeline, I think it's safe to say that there certainly has been a consistent thought among numerous administrations that at the very least, when patients and providers have the the right information, and patients as well, that they can more effectively make the right healthcare decisions at the right time. I think some of the newer phases of interoperability that we're seeing, I think all of us probably on the screen remember the days of meaningful use and its various iterations. But I think the new phase of interoperability goes a step further. It brings in health plans and tech developers really for more of a shared accountability and enabling access and exchange and the use of patient data. There have been a variety of policies that have been implemented over the past year. I think for the purposes of this panel, what I'll really focus on are those policies that are germane to interoperability and info blocking. Last year, CMS issued the interoperability and patient access final rules, which essentially requires that all health plans that are subjected to CMS's authority, so you can think of Medicare fee-for-service, Medicare Advantage, some of the federal exchange plans, Medicaid managed care, and the like, really requiring those plans to make certain health information available to patients and their caregivers. This information, there's tons of information that I can expound on, but just to summarize, we're looking at data such as clinical data, claims data, or even coverage related information as it relates to the patient's coverage with the particular insurer. Health plans are required to publish these standardized FHIR-based APIs or application programming interfaces that support patients getting immediate access to some of this usable health information to really, again, help them navigate their health journeys. Again, I classify that some of the information just at a baseline, we're talking about claims data, drug formularies, your lab results, and the plans have to make some of this information available really dating back to 2016, which I think is a separate conversation, but also highlights the fact that some of this information from a policy standpoint is backlogged, and we're needing some of the agencies to do a little bit more to give all of the necessary parties and who are responsible for enforcing this a little bit more time. The policy framework is also responsible for creating a standardized API for a provider directory, and also for creating kind of a payer-to-payer exchange framework, which essentially hold payers accountable for coordinating care based on the patient's request, which I think is largely unprecedented. CMS is exercising enforcement discretion at this time, and so they're not enforcing these policies really until July 1st of this year. The other policy that I'll just kind of highlight at a high level is the ONC info blocking rule, which implements the 21st Century Cures Act, which took effect April 5th of this year. It was supposed to take into effect in November and was kind of pushed back out. Information blocking, just by definition, is the practice by a healthcare provider, a health information exchange network, or any other designated actors that's likely to interfere with the access, exchange, or use of electronic health information. Essentially, through this final rule, essentially the Office of the National Coordinator identified 8 categories that don't constitute info blocking, so 8 exemptions, if you will. What we do know is that HHS and ONC, its subsidiary, that they're still working on enforcement dates for many of the actors involved with respect to info blocking. But from a healthcare provider's perspective, and Dr. On Demand is a healthcare provider, we still need enforcement mechanisms essentially from HHS, and that will likely come through future rulemaking. So as we're working with many of our payer partners, many of them are looking at their own systems, and we're essentially just kind of having conversations with them to say, okay, what can we do that's not too burdensome or doesn't kind of put the cart before the horse? Because as a provider, we're still waiting for clarity from many of these administrations, whereas we understand that our health plan partners have more clarity than we do to develop a lot of the standards, or at least the FHIR-based API standards that they're responsible for. I will say that there is one component in all of this that, as a healthcare provider, we're extremely excited about, and that's just, at the very least, the ability for ONC to kind of expand kind of the core data set or core data classes of data that they particularly that they have kind of jurisdiction of, to include kind of social determinants of health and more classifications for social vulnerability. We know that there is a need to look comprehensively at a patient beyond just their conditions and certain demographic data, and that if we truly are to serve the patient completely, and we truly are to engage and enable more of a coordinated care effort, that we have to know the patient completely. And so it's nice to see work kind of in development to add various classes that really kind of paint a much more complete picture for patients moving forward. So there's a lot of work that has been done, but certainly a lot more work on the way, and there'll be more to come in the next few months, hopefully.
Latoya, thank you. You know, this work has spanned multiple very different administration. You said API. Anna or Jocelyn, would you like to describe what an API is, just to bring people in, because that's a really cool concept.
I'm gonna let you go, Jocelyn.
Okay, sure. So I think that if we think about the way that every technology that you use today operates, it's essentially this ability for a service to call and inquire a repository to get the most recent information. And so I'll use a live action example. So you decide that you're going to try and figure out where you're going to go when you can actually leave your house and go into the outside world and see other people. And so you go to Travelocity and you make an inquiry to figure out, I want to go to Bermuda. What's the best flight that I can get? The way that Travelocity goes and communicates with all of the search engines of all of the airlines and the hotels is that they use an application programming interface. They basically have a standardized call that they can request data from every single one of the airlines in the same format, and it will return this predefined set of information to be able to be displayed. Or they'll be able to do things like book your ticket and select your seat and insert data back into that resource back at the airline's website, or transact or pay for it. To date, much of US healthcare hasn't used APIs. They've used big batch data files that happen, sort of on a scheduled basis, or they happen overnight, or maybe they happen weekly, in this concept of this real-time interaction between somebody in a provider organization talking to somebody else in another provider organization, or somebody in a provider organization talking to a payer to find out the most recent information in real time or near real time, is really a new concept that's being advanced through a lot of the policy and standards work that Latoya referenced. So Anna and I worked together on a project called Da Vinci, where many of the regulatory requirements that Latoya is describing are now being defined and set as samples. Everybody will now need to share this information between each other, and you shall use, and I call them recipes, standard implementation guides to get this work done. And I'll let Anna talk a little bit about sort of what the impact is of that, being able to do these things in these standard ways and not have to sort of custom write code or proprietary applications like Marion was discussing earlier to make this data flow. I mean, it seems like a really simple concept, but the fact that we're really unlocking and making healthcare operate like the rest of the world does has been game-changing in a very short period of time.
Yeah.
And that's, please, I talk about the partnership and the standards. That this is, I'm so thrilled that this is a huge message.
It's huge. And if you're here looking for opportunities and jobs, they're out there. We have them. So definitely take a look, because healthcare needs engineers and technologists and really smart people to figure this out for us. The reason why we need those standards, the reasons why we need all the partners to come together as a whole, is because a health of a person takes everyone to get there. It's not just your BMI, your body mass index, how much you weigh and how tall you are. It's not your heart rate. It's where you live. It's your financial status. It's your race, your ethnicity. We can't know everything, but other pieces and data and information can help a provider get all the pieces. So if I am a pregnant mom and I live in this area and this is my risk in going to this hospital. I'd be able to know that even as a patient, be educated if we can unlock this data, and we cannot do it alone. We need payers, we need vendors, we need providers to all get on board to being able to do this. And the reason why standards come into play is because as a provider organization, I want my providers to focus on care. I want my resources to go to the patient, to the community, to really change that death rate on our moms who are birthing, or to change that child wellness in our communities that we need, right? Because in the community I live in, childhood obesity is a big thing. So we want the resources to go there. We don't want to spend time, as I like to say, pushing files around, stamping papers. We want to be able to change that and make those things automatic so that the people doing those jobs who have been hired to do things like analyze the data, tell us where we need to improve, how can we improve, can do that job. Those people aren't doing that job right now. What they're doing is trying to figure out how to connect to somebody's inbox and grab a file and get it down with 18 passwords, and do that with 28 partners or 38 partners, floors of people, just trying to get files to go from point A to point E, and then talk to each other simultaneously. So without standards and a community come together on those, that's why we all have to partner. Our mission at MultiCare is partnering for healing and a healthier future. And we embrace that every single day we live that. We cannot do this alone. You can't deliver on societal health alone. You need the whole society. So that is why we really need to have some sort of standard in place. We're all going to agree to do this in this way together, so that we're not spending the resources trying to customize everything with every agency it takes to keep one human being healthy. So that's really why we're here, is to make that difference, to change it, to get adoption in the industry, and to make a difference. So I highly encourage you, if you're interested in being a change agent and making it happen, to get involved, because it does impact your life, because you will interact with healthcare at some point. That's all we have. That is all you can't buy it. So get involved, look up those jobs, come find us. We need people who really want to make a difference.
Hey, Anna and Jocelyn, there's this project called Da Vinci, and I learned about it when I was at CMS, Centers for Medicare and Medicaid Services. I'm just floored by it. It's got a beautiful name. What does it mean? Can you describe for our audience what Da Vinci is? Because it's really quite remarkable, and LaToya may know something about it as well.
So I think that there's a couple of things and I want to tag on to, I think, some of the really important points that LaToya made, right? We're basically sort of breaking down the wall gardens of information, right? And so in the industry, there's new technology. I think someone mentioned earlier, FHIR, which is Fast Healthcare Interoperability Resources. And basically it's a new standard and provides sort of technology framework for people to have basically a healthcare specific language to communicate with electronically. And about 3 or 4 years ago, which is crazy to think about it, that it's been that long, Marion, we basically got a group of payers and providers and vendors together to say, hey, building on another project in the industry called Argonaut, which first got the data out of the EHRs, right, as part of meaningful use. We basically said, could we do the same thing for payers and providers? Could we free the data by leveraging this new technology, this emerging technology, FHIR? And everyone agreed, yes, we thought that there was potential to do that. To Anna's point, sort of on a business problem by business problem perspective, could we write implementation guides, recipes to get us to a place where people could have a consistent, reusable way to be able to communicate, not just with one partner, but with multiple partners, to really, take that waste out that you could hear Anna talking about. I have one provider group that talks about the fact that they have 60 different formats that they communicate with people just to decide which patients they have in common with their health plans, right? So 60 different ways, all brittle, all custom, that can break on a regular basis. And how do we apply the technology to be able to do that? So we now have about 50 organizations that are funding and participating as sponsors in the project in some way. And I would say hundreds of organizations now that are actively implementing. The July 1st deadline that LaToya described is actually the first time that there's a regulation in place that people need to start to use some of these implementation guides in production. And what we're seeing is this sort of rebuilding of the way that payers and providers work with each other to focus on sort of the clinical data that's necessary to get people the information they need to really impact change with that provider in that patient. And then also, how can we take as much waste, right, out of how much, just reuse out of the world, so that patient gets the care they need, the provider spends as little time and overhead sort of making that happen. And Anna and the Cambia team, so Multicare and Cambia are like my stars from a program perspective. They really have been out there ahead of the pack, starting to implement some of these guides in production, I think with really meaningful results. And I'm going to toss it to Anna with a little bit of a forced sort of entry point, but they're a great example of sort of this concept that Anna refers to as the team of teams. How do we make this change happen? How do we work across sort of the barriers, walls of people's organizations to actually take all of this good stuff we're sort of baking and actually put it into real world use operationally between partners? So.
Yeah, it's most certainly, Jocelyn, a team of teams concept. And that is the new world. And especially when we go back to that core question, like, what is interoperability? It's also like a team of teams of humans working together for one thing and to achieve a goal. And it's going to be really important. And that really truly was the secret sauce to the success that we've had in implementing these implementation guides, is that we understand their business now and they better understand our business. And now we're figuring out how we can help each other even more. Just one implementation guide has truly, number one, in the development cost pays for itself in the first year, and then for every year after. And Regents will be a pair of ours for a very long time. And we'll be able to use this same guide, this same endpoint, this same API, just like Jocelyn was referring to with Travelocity, for all of the payers that we partner with across our service areas. So we were able to really impact the way we share data with one measure. So it's called Med Reconciliation. So we're going to get deep here. It's called medication reconciliation. If you have an inpatient surgery and you leave the hospital, it's our job, and we are held accountable to in our quality measures with the government, to call you and get you an appointment in 30 days. We'd really like that to be 7 days, but 30 days after you get discharged, so that we can go through all your medication and ensure that you understand it, you can take it, none of it is counteracting itself. It's called Med Reconciliation, we call it. More affectionately, acronym MRP. So with MRP, just by reaching data parity, we were able to find 40% more of those MRPs that we were doing. We were already doing this work that we couldn't find in a normal means of exchanging data and getting it to a payer with this method, meaning that now we expose the people who really need it. We're not double doing it. The resource shifts to the people who really need it, who really need that phone call, need to get the follow-up. It's really a thing that improves health outcomes. It improves their readmission rate back to the hospital, to the emergency department. So it's a very important measure. And being able to shift those resources where they are most needed is really important to us. And we achieve that through data, through technology, not touching the provider workflow, not doing any of that, just through tech. So it was really powerful to see this standard in place that now is scalable solution to the rest of our payers that we interact with. And now we can take those resources and push them back down to the patient where they belong.
Can I ask, we'll stay deep, thank you. Can I ask other use cases just to give people a flavor of these big problems you're tackling? Because they're huge. So chime in, everybody. What other problems is Da Vinci tackling?
I'm going to loop it back to Latoya a little bit because I think this is an important point. So we have a number of use cases that are about how do you make the data flow from the payer to the provider and from a provider back to the payer or to another provider. And so if you think about the example of somebody in a telehealth visit, right? So Latoya is seeing somebody, maybe she has access to an EMR that's local depending on the arrangement she has with a particular hospital system. Maybe she's seeing the the patient completely blind and has no background information. There's an episode of care. How does that data and that interaction and that richness of all of the work that happens while that virtual visit is occurring, and a doctor like Latoya wants to get that information back into the patient record for follow-up by the primary care, or if it's a behavioral health visit, or if it's a lab, or if there's follow-on labs, how does that data flow? We're literally building the specific instructions, the recipes to say, how would we take provider data coming out of an EHR and get that to the payer so the payer knows that this happened and they can share it with all the other providers? Or how can that provider, because they're in a close network relationship, how can that provider get that data to another provider? And how, when I see that patient for the first time, if it's an urgent care visit, that payer has a really great view of everything that's happening around that patient. How can at minimum, if I can't get access to the patient's home EHR and see their record as it exists today, how can I at least get a footprint of what that patient looks like? And that's some of the APIs that are going into production in July are about how to get the patient their own information. In following years, we're expecting that same requirement will be to get to the provider. And so that how can that rich information that the payer has about the patient be available to any care provider at any point in time? And then I would say the topic that probably gets the most attention is our work around prior authorization. And so we're really doing, it's like people like jump up and celebrate, but it's really not even just about the act of the prior authorization itself and getting it submitted and getting it approved. It's really about this idea about information equity. How does the care team understand what a patient's benefits are and what is covered by your health plan and what are your costs associated with that? Because intrinsically, we made a decision, 30 years ago that prior authorization was this administrative transaction that had nothing to do with your clinical care. And so it became this back office activity that happened. And as we move towards changing the relationship of how payers and providers work together, and we understand that intrinsically sort of what's covered by your insurance is innately tied to whether you're going to be adherent, whether or not you're going to be able to follow through on that care plan, that ability to bring back that information ahead of the decision making or as part of the decision making. So you're not just doing clinical decision support, you're also getting administrative decision support. We're working on the APIs that will help make sure that you as a provider, when you've got a patient in front of you, have a clear picture of what's actually covered by that patient's insurance. And if and when you need to, do the prior authorization. But often we're expecting, and I think our goal is to really reduce or remove the need for prior authorization because everybody understands what your plan covers versus what somebody else's plan covers. So if there's an alternative that's on your formulary, or there's some sort of the step process, like you need to go to PT before you can have your knee surgery, that's transparent to everybody. And it's not this process that takes a month to get through and delays basically your access to the care that you need as a patient. We have a number of other use cases that are really sort of centered around and supporting that. And then we're also helping providers better signal patients that are at higher risk so that they can become part of programs and incentive programs so that the provider can get the dollars in-house to be able to have the advanced programs to get to those sicker, more at-risk patients and get them the care that they need.
Thanks. I want to pitch over to Latoya to talk about the new rules, and be careful, Latoya. I was part of the team that wrote them at CMS, so I'm very proud of that work. It's part of my heart and soul. But these are big problems, folks. The physicians in the country, if you survey them, according to the American Medical Association and many other groups, number one frustration is not the electronic medical record, it is prior authorization. The process is not good enough. It's broken. So this type of approach is common ground. It's a way to improve the process. So it's huge. But Latoya, before I ask you all about what the barriers are to interoperability, would you like to comment a little bit about the recent interoperability rule?
Yeah, I'll say this. I think what you've done, Marion, without me necessarily having to like explicitly say it, is to just let the audience know that you too can be a policymaker or support policymakers and have such an impact. I mean, we are essentially talking about work that Marion has touched, like golden touch. So I appreciate that and thank you for that. We need as many folks like myself who are there creating frameworks for policy, knowing that not often the policy is not keeping up with the fast pace of the moving of the technology. So just wanted to highlight that. I think from Doctor on Demand's lens, again, just knowing that we're a virtual care provider. We're the ones who are providing care to patients across the entire life cycle of care. And I wanted to highlight two things. One, it's extremely important to note that these policies are going to have a tremendous impact on the most vulnerable. We're talking about Medicaid beneficiaries, Medicare beneficiaries, those who are entering into federal exchanges, perhaps for the first time. I know that in our assessment of just kind of looking at profiles of Medicare beneficiaries, oftentimes Medicare patients have 7 different healthcare providers. They're seeing 7 different healthcare providers, probably to treat a variety of conditions. But if you can imagine just how fragmented of a journey that is for not just the patient, but also the patient's caregiver, to be able to unleash some of this data, but also to create the appropriate frameworks and infrastructures so the appropriate partners are speaking to one another. It really is a way of valuing both the patient and the caregiver's time. I think for us too, we're really looking forward to working with our health plan partners in some of this endeavors, because a lot of the rules are really about focusing on payer work and plan work, but we're really looking forward to them because we believe that the information ultimately that we derive from our patients are going to allow us to provide better tailored care. It's not, again, about checking the box about HL7 diagnostics or ICD-10 codes or, which boxes the patient really fit in. It's about really learning more about the patient and, again, trying to figure out how we can help that patient navigate their care journey. You may have seen a doctor on demand physician or healthcare provider for primary care needs or a behavioral health assessment. But if we can identify that you need more and we can help you get there and we can ensure that you actually get there, and don't defer care like 1 in 3 adults did over the past year, largely due to COVID. And if we can leverage the power of technology and information to do that, I think that we'll all be better for it. So we're really looking forward to working with our health plan partners on that.
Hey, folks, I've got to keep us on time. We have 4 more minutes. I'm going to ask you in round robin to describe a barrier and a place where people can go to look for more information, like, for instance, Da Vinci or the Caring Alliance. Jocelyn, I'm looking at you. I'll have you start.
I totally cheated. I just put all my links to Da Vinci in the chat. So I do think, and I want to amplify Anna's point. All of us at the end of the day are change agents. And we don't just need technologists. We need people that understand these workflows. We need people that have first-hand experience as caregivers and as actual patients to participate in sort of building out this universe. I think that I will say that there are very few points in time in one's career where literally the world around you changes how it operates. And we are at that inflection point in the way that healthcare operates. So I think our biggest barrier is going to be finding more Annas and more Latoyas to drive the industry forward and really build sort of the next generation of experts in this area to really make the change happen. And I think that through these projects that we're doing out of HL7, Da Vinci is what is as part of an accelerator program where we're bringing together the right smart people around a particular topic. I also shared Gravity, which is focused on social determinants of health, is doing amazing work. Every community needs people, and we're helping to develop and I think overcome the lack of sort of expertise by basically building that generation as part of these industry projects.
Latoya, barrier and where they could go to get more information that you think would be helpful.
Sure. I'm going to start with the barrier. Two. I think one, from a policy perspective, we're all still waiting for more clarity. So I think more clarity from HHS and their respective offices at the Office of the National Coordinator, from the Centers for Medicare and Medicaid Services. I will put a plug in for the folks at the Office of the Civil Rights, because we know that there are some proposed rules out there for HIPAA, which means that we're going to be addressing privacy and security in a separate set of rulemaking and trying to tie that all together with things that have been done and will prospectively be done. So one, looking for more clarity. To Jocelyn's point, making sure that policymaking is inclusive. It can't just be providers and health plans and tech developers at the table. I think patients themselves are serving new roles in their lives, one's as patients, but also as caregivers. I myself as a caregiver by proxy, when my dad is a little too tired to take care of my mom full time. So I'm happy to do that for him. I will just say, I think that I wouldn't call it a barrier, but I think that there is something that we all need to be aware of. We should be aware of the moment when the data highlights something that maybe we weren't prepared to accept. And we should be prepared with an appropriate response as to how we're going to deal with it. I think that we're going to be releasing a lot of information that I don't think the healthcare system is going to be too happy about. We're going to be pointing a lot of fingers. Folks are going to say, how did that happen? Who was responsible for that? Who missed it? But at the end of the day, we've got to respond to how it impacts patients, what the downstream effects and impacts are. I think Jocelyn, I'm sure Anna have provided tons of information. If you aren't currently engaged in the various working groups that I know that ONC puts on, I'm sure Marion, you were part of them as well. Some of them are some you have to be self-selected, but others I think are just kind of free and volunteers. There are tons of associations out there that you can join. HIMSS is one of them. I know that they have different chapters across the country and are constantly looking for feedback and input. I will also say that there are probably additional opportunities for patient-generated information that I don't think that we've particularly scratched the surface at. But those are some of my final comments. I'll turn it over to Anna.
Thanks, Latoya. I'm going to try to address the three questions that I see in here. Just in what Latoya is talking about is that there are barriers. They can be positive and negative barriers, such as how do we approach when a provider isn't appropriately using data and information to give care? These are things we have to be thoughtful about. I'm not sure if you've watched the latest Netflix on the AI Justice League. It's awesome. You should watch it. Out of MIT, and how they're really trying to bring principles to the table around how algorithms create inequities. These are some of those same things, like how does exposing these data points create inequities? It's going to expose more problems. And just as Latoya said, we got to address it and talk about it and do it. Somebody once said, even myself, I've said, but what if they use my data for bad? What if that happens? And somebody said, are they really going to do that? And I go, I think some people might, because not all humans have good in them. At least in my experience, that's my coming to age epiphany, is that, oh gosh, I thought everyone was good when I was little. So there are going to be these really hard conversations we have to have, and we just have to be prepared to do it together as a team, as having this goal to make a human's life better. That is what we have to do. And we're going to have to take it one step at a time. And we're going to have to be a good human and do good. So all the stuff on more information, Jocelyn has already shared. Da Vinci's where it's at. So come join us and come play with us. It's really fun. And then more information on CMS, start looking at the Centers for Medicaid and Medicare Innovation Center, because those are the financial models that drive the exposure of the data elements. So follow the money and then follow the information. That's step 2. So go ahead and look up those and see what's in your market and see if you can get involved.
You guys are awesome. What What a great team. Thank you. I think we go to breakout rooms next, and then we'll reconvene after that.
Hello, hello. Thank you for this wonderful discussion. My mom is a physician, and she's the very unofficial counselor for our biotech day. And I showed her the roster, and she's like, yes, this one, because the frustration is so high. And they had so many issues this year, especially with COVID testing and patients coming in and delaying surgeries. And it upended everything. So it's such a comfort to know that there's people out there making this work and making it better. I'm looking at our breakout rooms, and we actually don't have a lot of people left with us. And I'm thinking we should skip the breakout room and keep it open in here in the discussion. This sometimes happens. People decide not that they don't want to participate. So I'm gonna let the audience take themselves completely off mute and open it up for a full-on discussion. I know Betty was asking a lot of questions in chat. So Betty, I'm calling you out, but I wonder if you have, if you want to address it to the panelists. And I'm also gonna put in the prompt question in the chat, which was, how has the pandemic moved the needle? What has changed for the consumer that won't change back? So let's open it to everybody who is still here with us.
Yeah, maybe I can start. I'm Betty. I'm curious. In this healthcare industry, there are actually many things that I think is very personal impact, like to me and to my family. One of the thing is like some of the healthcare provider that I know, they chose to not deal with the insurance at all. Simply, some of the things I heard from them is like, it's just too much work to simply handle the paper. And then sometimes they got rejected, and then they if they just do without, then they don't have to hire someone to just do that billing. So it's kind of sad for me to hear that. I know that's for some, I still choose to use their service, and then I will be the one to deal with all that claiming for my health insurance and all that. I wonder if you have some opinion on that can share.
Betty, I'll take that because I practiced for 3 decades, and I always accepted as part of large health system and academic health systems. I think I counted 24 different carriers, and including Medicaid, and we tried to be as inclusive as possible. We also had, as a nonprofit, the obligation to give charity care when someone was not able to have insurance. We tried to get them enrolled in Medicaid if we could. It's going to vary from health insurer to health insurance, and I don't begrudge people, especially clinicians, the ability to practice the way they want. And I think what you might be referring to or alluding to is that we've made the practice of medicine very complex, and it's very frustrating, and we're having moral injuries so that clinicians, for instance, went into medical school to care for people, and yet they're bombarded with all these different regulations and all this different compliance issues. And you're right, prior authorization is one of them, and making sure they can get claims accepted. So I would say to you, my hope, my nirvana is we fix this administrative burden with standards. And we don't, I call it the Post-it syndrome. If you go into a physician's back office, there's 20 different Post-its on a monitor because they've got to go into all these different portals for all the different carriers. That's not helpful. That's why these standards are so important. So it's leading to a lot of waste, a lot of burnout. And I just would say to you, I'm sorry that you're experiencing that. It's not good. But I think the interoperability is actually key to some of that, key to fixing some of that.
Chelsea had a question about privacy laws. In particular, how do you expect privacy laws to impact the way data collected and is shared? Chelsea, you're welcome to hop on and expand on this, or I can open it to our panelists, because I keep thinking, like, in Washington, we have very strict privacy laws about, like, we can't even change. We have issues now with our driver's licenses because they don't match what the federal government wants for us to travel, etc. And I am wondering, how does this impact healthcare? Like, if I move, let's say if I live in Washington, but I have an accident in Idaho, like, can they access, for example, my medical record from Washington? Or am I really simplifying this completely right now? And feel free to correct me or adjust, please.
I think from a policy level, just quickly, what I'll say is yes, policy laws will certainly have an impact on, one, how information is collected, two, how it's shared, and how we reinforce protections on both consumer and patient information. I think it's important to note, as you did with the example of Washington State, not only are we dealing with a federal framework for privacy and security, but we're also dealing with 51 frameworks for privacy and security as well. So if you can imagine that right now we're kind of in this really great inflection point for healthcare. I know I can talk about it from a virtual care standpoint, where people are seeing healthcare providers across state lines with various laws enabling cross-state practice, but knowing that when you're in a state and your provider's in another state, ensuring that your company is fully aware and fully compliant with the laws in both states, and protecting the patient's information based on where they are. So in short, I will say that yes, very much so. That the laws certainly will continue to have an impact on that. And as I mentioned briefly, we've got this wonderful multi-100-page document that is HIPAA that I'm sure both Jocelyn, Anna, and I'm sure even Marion will take a peek at, because comments are due in just a few weeks. So just one more thing to tackle.
So that's why my Kaiser person online always asks me for my zip code. They're most likely like in California or something when they're talking to me here. Erin, you have your hand up, so go ahead and take yourself off mute.
Hi, this question is for all of you, but also mostly Dr. Marion Couch. When you were talking about the administrative burden and the physicians with all the different portals, have you heard of any positions like a patient navigator or a scribe that does that all for the physicians and like follows them around? And do you have any opinions on that? I'm in grad school right now, master's in entrepreneurship at UW, and that's one of the things they do.
Yeah, Erin, the scribes traditionally take notes. They're in the office with the patient and the physician, or the nurse practitioner, or the physician assistant, and they'll take notes. And then we have medical assistants that are also helpful in terms of applying for approval and writing prescriptions and renewing it. So that's been an extension of providers, but without the data plumbing, it only goes so far. So scribes are wonderful. Oh my goodness. And by the way, a lot of them go on to be healthcare providers. It's really awesome in that regard. But it's just one end of this big spectrum. And it'd be like, I would say to you, Erin, it's like building a great dining room, but you still have to have the living room, kitchen, And for that, you'll have to have the good plumbing to get the data everywhere.
And I can add to that one. Oh, you want to go, Jocelyn? You can go first. You're on mute. You're on mute.
We spend a lot of time together. I think that I was actually going to ask for you or Latoya to talk about this concept when we think about it from an industry perspective, about getting people to operate at the top of their license or their highest best purpose. Because I think that when we look at all of this work, and even tying back to, I think, the question about people that choose not to take insurance, I think the more that we can spread the work across the right person at the right time to do the right task, I think that's invaluable. But as that gets more challenging and more burdensome, we narrow, right? When somebody opts out to not participate in the health insurance market, that takes a provider out from everyone, right? And reserves it just for the few that can actually cash pay, right? And then chase their insurance for coverage. So I think it's something that we need to really think hard about. But I do think I'd love to hear either Latoya or Anna's thoughts on this concept of, like, how are we making sure not only are we getting the right tech in place, but we're sort of putting the bodies in the places where they're most effective.
Anna, did you want to add before I chime in? Okay, great question, Jocelyn. I'll say from Doctor on Demand's lens, just 6 or 7 years ago, I think like other virtual care providers, we thought we could really fill the gap on urgent care. We can provide maybe that 15 to 20-minute visit. And it was our patient feedback loop, our provider feedback loop, and the various outcomes data that we were able to glean just from our patient interactions and claims data, where we realized that we needed to build in the capacity to provide follow-up care to these patients, that it wasn't just a one-off kind of transactional encounter, that patients often needed to talk to someone after that particular visit to follow up to make sure that they were adhering to care. But then we also realized that we needed to expand our care team. And so over the past 7 years, we've been able to add a rather interdisciplinary care team that includes psychiatrists, psychologists, a slew of behavioral health providers, including marriage and family therapists, psychologists, licensed clinical social workers, nurse practitioners, because the physician can't do it alone, that the patient often needs a care team to help them navigate from either one part of our practice to another, or to the specialists that operate outside of a doctor on demand, but that fit within the payer's network for additional care. And sometimes might need to follow up again with the doctor on demand primary care, right? That feedback loop. So we've evolved, even as a virtual practice, to realize that our care goals, whereas maybe they were filling the gaps for urgent care many years ago, our care goals today are much more sophisticated and much more patient-centered.
Yeah, and just like Latoya speaking to that in a interdisciplinary team, as you get familiar with the different financial models being proposed by government payers that commercial payers then adopt, you can see they're trying to figure out what works best. How can we create a care team that's going to make the best outcome for those patients? And every human's going to be different, so every human's going to need different recipes in that care team, right? I need a primary care doctor. That's what I need the most of. And this person needs the most of a psychiatrist, and this person needs the most of something else. PT, whatever it may be, they're trying to figure out what is that care model, especially around chronic diseases. So you can get familiar with those models. Those speak to your patient navigation part. But as far as that, if I go to the emergency room in Idaho and I live in Washington, you go to UW, go Huskies, they have all my money too. They have to click like 18 times to get there. I'm here to tell you, there's a better solution that needs to be developed. So I'm posing that to you guys who are still with us. Find us a better solution, because what's in place right now, I have to advocate as a patient. I just went to here. Can you please go check my care everywhere? Because I'm not doing that again. And I only know that because I sit in the industry for 13 years, that I can ask them to do it. And then they click and, oh yeah, you did. Cool. I got it right here. I can see. All right, well, we're going to do this, this, and this. A better care decision for me. But I know about that. Not everyone's going to know about that. So that's a problem we need a solution to. And hopefully one of you can solve that for us.
Miss Taylor, I see you're at Multicare. Is Multicare one of the ones like Kaiser where you want your patients to just stay in Multicare? Or are they like a la carte picking providers?
Yeah, we have Multicare Connected Care is both independent providers, and we have Multicare Health System, which is a large tin of those providers. It's not the majority, however. We have about, I think, 4,200 in our network now. I think our website probably says 3,800, but I think it's gone to 42. And about 1,800 of those are multi-care providers, and the rest are independent practices. So they own their own business. Our mission is partnering for healing and the healthy future. It's not taking over the world. So we really want to make sure that we're empowering those independent providers and community partners, because it's not going to just be care providers, it's going to be social services, it's going to be women and children, it's going to be the church, it's going to be all the gym down the street. It's going to be more than that that makes a human healthy. So our network is not just Multicare Health System.
Marion,
Go ahead, Jocelyn.
I would just add one point about that. I think when we think about sort of the traditional relationship of like a Kaiser or a Geisinger, if you're out on the East Coast, that is more of a Harvard, that's more of a closed network. I think that we're seeing shifts in the industry, and I think both Latoya, Marion, and Anna all referred to this sort of changing and how we pay for healthcare. And so as we shift healthcare payment more towards value, actually making patients healthier and keeping them healthier, I think that the sort of more traditional constraints that we've seen in healthcare will sort of fall away, because everyone's going to want to be incented to get the patient to the right place and to get their care in the place that's the most convenient for them so that they're adherent with whatever their therapy is. And this is what I mean, like fundamentally that we're changing. Not everybody's doing it today, right? Anna and I get to work with the people that are literally at the pointy tip of the spear. Latoya is actually the tip of the spear doing all the virtual care out there. But we're seeing the way that people transact and how they interact. And going back to the policy work that's happened, one of the initial things that payers have to provide is literally a digital version, an API that tells you who's in your network and what's on your formulary, right? And that seems really simplistic, right? But for anybody that's ever had to make an appointment someplace outside of your primary care and figure out whether they were in network or out of network, and if it's an episode of care that involves multiple people, whether every person that touches you is in network or out of network, that's game changing. And then add on top of it, we're adding additional requirements that are coming out of the feds to say, not only that, you have to tell me how much it's going to cost before you touch me. It's game changing, and it's going to make healthcare more like the other industries we interact with, right? The goal is to free the information so that we can, as consumers, drive our care and really be able to make those active choices about where we get care that works best for us at a price point that makes sense for us. And the payers and the providers that are like Anna, becoming more like payers and providers in the same place, the ones that do that well and provide high levels of service are gonna accrue more patients, right? So we're gonna have a level of competition that just hasn't existed to date in healthcare.
It sounds like you're hopeful for better
You
future,
can't
right?
do this work if you're not hopeful.
Yeah. There's so many possibilities. It's gonna be better. I'm gonna make it that way.
You know, Jocelyn, that the CMS administrator made national headlines when she said just a little while ago, patients own their own medical data. And this was and I'm just like, it's
She
really,
also said we needed to kill the fax machine, right?
yes.
And that was controversial.
Right. But there's these big changes. So it's really exciting to see the transformation. I've never seen anything like it in my 30 plus years of practice. This is a moment in time, folks. And I just hope we keep leaning into this transformation. And again, Da Vinci and those types of projects are just awe-inspiring. I just loved it. When I got here and saw the work that was being done, it just really made me happy because, hopefully this new administration, and I suspect they will, because it started with the Obama-Biden administration, will continue to push that forward because it takes both, right? It's a public-private partnership. And then these other smaller partnerships are just huge in all of this. It's just marvelous.
I think,
go ahead.
I was just going to say that I think, is it strange to say COVID silver lining? I think that so much of the public at large knows so much more all of a sudden, from terminology to how to get care, how to find care, how to be more savvy with finding care. So because I've been around doctors my whole life, and doctors only talk about doctor things. So I always feel like I know a little bit more when it comes to
talk about rowing.
As an anesthesiologist. So all I heard my entire life is stories about that with doctor friends. So I always felt like I know a little bit more when it comes to navigating the system, especially in the United States. But just from talking to my circle of friends, they're becoming more and more savvy just because of this year and because of all the media information that was put out there, and also by physicians and hospitals and states who became such strong advocates because the previous administration failed so much. And I felt like, anyway, I just felt like I agree that there seems to be a new path, and people want better care and they demand better care, and there are resources out there for them to find it. And anyway, I'm very much like a little bit high right now from this discussion. It was wonderful to listen to you all throughout my day doing my WIT Zoom.
Well,
Zoom
we
talks.
appreciate the cat camera.
Yeah. Marian, any final thoughts as we
Oh
are
my
closing
goodness.
this
I just,
session?
it's a great way to end the day, folks. And it's dark here, so I truly is ending the day, but thank you. Again, Anna kept alluding to it. If you want a great career, lean into this work. It's really work worth doing. I come to work excited every day, and I don't get to do projects like this all the time, but this is really the highlight, and we'll change the world. It's really great stuff. So again, what a great team to row with. Thank you guys.
Thank you so much, Cambia, for putting together this event and the previous panel as well. I know there was so much work put into these panels. Thank you, Latoya, Jocelyn, Anna, Dr. Couch, for taking part in this conversation. Thank you for a wonderful audience for participating. Thank you for making this a big breakout room and for sharing. The sun came out in Seattle, so I'm going to start my evening walk sooner. Sam over there is going to do the walk with the leader tonight with Melody, Sunset Walk. So you're welcome to join us later for that. And I'm going to sign off. I'm going to end the call. And everybody have a wonderful rest of your day and have a good night over there in the East Coast. Bye.
Bye. Thank you.
Bye.